Dr. Eric here to discuss prostate enlargement, or BPH, and its treatments. As men age, most will experience an enlarging prostate, a condition called BPH, or benign prostatic hypertrophy. The prostate, about the size of a walnut, sits at the bottom of the bladder, with the urethra running through its middle. As the prostate enlarges, it can restrict urine flow by pinching the urethra. This can lead to a slow, stop and start stream, straining, and incomplete bladder emptying. Men may also experience frequent, urgent urination and waking up at night to urinate. Untreated BPH can lead to bladder dysfunction as it works harder to push urine through a constricted tube. Imagine blowing up a balloon through a straw. It requires much more effort, similar to the bladder with BPH. With BPH, it's not the prostate size that matters, but how it grows. A small prostate growing internally can cause significant problems, while a large one growing externally may not affect urine flow. Once BPH is identified, we assess how bothersome the symptoms are. Questionnaires like the AUA symptom score are commonly used to grade disease severity. Other tests, like a bladder scan, evaluate how well the bladder empties. Urine analysis is always performed, and sometimes a cystoscopy, a camera exam, use the prostate and bladder internally. An ultrasound can also measure the prostate size and shape. Urodynamics, which studies bladder function and prostate squeezing, is also sometimes used. For men under 70, a PSA test is done to check for prostate cancer. Based on these tests, a treatment plan is developed, starting with watchful waiting. This is for men with minimal symptoms, involving monitoring and treating only if symptoms worsen. The next option is medications, with 3 main types used for BPH. Alpha blockers, the most common, relax prostate muscle fibers to open the passageway. 5-alpha reductase inhibitors reduce testosterone conversion to DHT, a potent version, within the prostate. This DHT decrease shrinks the prostate, effective only for large glands and taking time to work. PDE5 inhibitors, known for erectile dysfunction, are also approved for daily use to improve prostate symptoms. These medications can be used alone or in combination. If they fail or cause bothersome side effects, surgical options are considered. 20 years ago, there were 2 prostate surgery options. Now there are nearly a dozen, each with pros and cons. This allows for fine-tuned management, with the right surgical option often depending on prostate size. Like Goldilocks, prostates can be too big, too small, or just right for various procedures. For small prostates under 30 grams, options include TUP or urolift. TUP, or transurethral incision of the prostate, involves inserting a camera and instrument through the penis to cut grooves in the prostate, relaxing the tissue. This is done in the operating room under anesthesia, with the catheter potentially used for a day or so afterward. The urolift procedure uses a special instrument to deploy pins into the prostate, pulling the tissue open. Imagine the prostate as closed window curtains. Urolift opens and ties them back. This procedure can be done in the office or operating room via a camera through the penis, often without a catheter afterward. For medium-sized prostates, typically 30 to 80 grams, there are more options. These include urolift, TRP, rhizome, and aquablation. For larger prostates, urolift requires more pins for the desired outcome. TRP, or transurethral resection of the prostate, is a decades-old procedure, often called a roto-rooter job. In the operating room, a camera and special loop are used to carve away prostate tissue until the prostate is wide open. TRP variations exist, differing by the instrument used. For example, Greenlight TRP uses a laser to melt tissue. The plasma button works similarly, known as photovaporization. A catheter is usually left in for about 3 days, sometimes requiring an overnight hospital stay. Resin therapy is a newer, excellent technology, usually performed in the office. A camera is inserted and steam is injected into prostate areas, causing cells to melt away over several weeks. A catheter is typically used for about 3 days post-procedure. Aquablation is also newer but not yet widely used. It's a promising technique using a high-pressure water jet to strip prostate tissue under ultrasound and robotic guidance. This is done in the operating room under general anesthesia, requiring an overnight hospital stay and several days with a catheter. It's like using a hose to clear dirt. Complication rates are currently high, needing improvement for wider adoption. For large prostates, typically over 80 grams, there are two main options: simple prostatectomy and HoLEP. While urolift, rhesum, and aquablation may be considered, they are less effective for larger prostates. A simple prostatectomy is abdominal surgery. Imagine the prostate as an orange. The peel is opened, the pulp scooped out, and the peel closed. A large amount of tissue can be removed quickly, with surgery lasting about 90 minutes. A catheter stays in for 7 to 10 days, and an overnight hospital stay is necessary. HoLEP, or holmium laser enucleation of the prostate, is similar but uses a laser through a camera in the urethra, avoiding abdominal incisions. The prostate is cored out, pushed into the bladder, then a morcellator breaks up and removes the tissue. An overnight hospital stay is required, with catheter removal usually the next morning. Both simple prostatectomy and HoLEP are hospital procedures under general anesthesia. I excluded microwave therapy and needle ablation because most urologists find them significantly less effective than other treatments. Most urologists no longer offer microwave therapy or needle ablation. I hope this overview is useful. Please subscribe for more health videos and leave any questions in the comments.